Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Marketing and Public Relations at RUMC. We have our guest of the day, Dr. Daniel DeMizio, RUMC's newest rheumatologist, and Dan Ryan, the advertising director here at the Staten Island Advance. Welcome. Thank you for joining us. Through RUMC Connections, you'll meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. So let's talk rheumatology. A rheumatologist is an internist or pediatrician who received further training in the diagnosis and treatment of musculoskeletal disease and systemic autoimmune conditions commonly referred to as rheumatic diseases. These diseases can affect the joints, muscles, and bones, causing swelling, pain, stiffness, and potentially cause joint deformities. So our guest of the day was born and raised in Staten Island, New York. Dr. Daniel DeMizio obtained his undergraduate degree in biology, summa cum laude, at the College of New Jersey. He was inducted into the Alpha Omega Alpha Honor Society while a medical student at Albert Einstein College of Medicine. Dr. DeMizio subsequently completed his internal medicine residency at Mount Sinai Hospital in New York City and his rheumatology fellowship training at Columbia. Dr. DeMizio is currently an assistant professor of medicine at Columbia University. Dr. DeMizio was previously an assistant professor of medicine at Columbia University College of Physicians and Surgeons. Dr. DeMizio's particular academic interests include vasculitis, quality improvement, and musculoskeletal ultrasound. He served as the director of the Vasculitis Center. Dr. DeMizio also has a particular interest in medical education and was a member of the clinician educator track during his residency. He remained very involved with teaching medical students, residents, and fellows at Columbia, and he is currently teaching medical students and residents here at RUMC. While he was at Columbia, he served as the rheumatology course director for medicine residency and fourth-year medical students. So welcome once again.
Thanks for having me.
Maybe you can enlighten us. What do you think are some of the most common rheumatic issues and why?
So rheumatology is an often misunderstood specialty within internal medicine. We, as rheumatologists, basically treat two major conditions. We treat diseases that fall under an umbrella of musculoskeletal medicine, and we also fall under and treat diseases that fall under autoimmune or inflammatory conditions. The common diseases that we treat within those kind of major two subgroups, musculoskeletal medicine is things like osteoarthritis, kind of bone-on-bone arthritis due to aging and wear and tear, things like bursitis or tendinitis, irritation to the tendons or the fluid-filled sacs that kind of help cushion our joints, and things like sports injuries or sprains that might happen to the muscle or the tendon. So that's kind of the more bread and butter under musculoskeletal medicine. But then the kind of perhaps more interesting or more challenging to treat are those autoinflammatory or autoimmune conditions. And those are things like rheumatoid arthritis that you might have heard about, psoriatic arthritis, lupus, and then kind of more rare zebra diseases like vasculitis or myositis that people might have never even heard about.
So it sounds like from your description of what you're treating that a lot of these conditions are either something that someone is born with or they come about with age.
So that's a really good question. It's a little bit complex of an answer. For some of these diseases, like osteoarthritis, they are very much tend to be age-related. If you live long enough, about 20 to 30% of people over the age of 60 will have osteoarthritis in their knees, for example. Mm-hmm. And that's a disease that tends to develop, more with age. Some of these inflammatory and autoimmune conditions actually can affect any age group. So we have patients with rheumatoid arthritis in their childbearing ages in their 20s, 30s, and then those same people can also develop rheumatoid arthritis later on in life in their 50s or 60s. So a lot of these autoimmune conditions really can affect basically any age group. You mentioned kind of genetics or something that you're born with. The cause of these diseases is not fully understood for the majority of them. There probably is some genetic component, almost certainly, for the majority of them. Things like lupus and rheumatoid arthritis and psoriatic arthritis. We do know that there definitely is some genetic underpinning to them, but it's a lot more complex than that. It has to do with, environmental factors, occupational exposures, things like periodontal disease. So there are a lot of factors that go into it. It's not simply, oh, my mom had it, therefore I'm going to have it. That sort of thing.
So it's a pretty broad spectrum of.
Absolutely, yeah. We treat all age groups, from young kids to 100 years old.
And you mentioned it's a very, I'll say, small specialty in internal medicine.
Yeah, absolutely. We're actually the smallest specialty within internal medicine. There's about 4,000 rheumatologists in the United States, number, give or take, obviously. On Staten Island, there are very few rheumatologists. With a quick Google search, I see about 10. And then, a lot of of those rheumatologists throughout the country are retiring or kind of later on in their careers. So there's expected to be a rheumatology shortage in the coming years. So we're a much needed and sought out specialty.
So you're arriving at the right time.
Yeah, absolutely. Yeah, coming at the right time.
That's a wild number to think about. There's 500,000 people on this island.
Yes.
And
there's
maybe
only
10 rheumatoologists. Again,
Yes.
that's not like a firm number, but that
Right.
it's and I know many of them are retiring or already have retired on the island. So it's tough
You are in
to
need.
find.
Yes.
I am in need. Yeah.
And when you think about doctors, you don't think about how many others there are. For example, we had Dr. Brian Gilchrist on in a previous episode as a pediatric surgeon.
Right.
And he's one of only 475 licensed pediatric surgeons in the country.
Right.
When you think about that, and then you think about a small place like Staten Island, like, wow, we actually have one. We have you now. It's like, well, I don't have to leave to find this specialist, because that's always the thing is I've got to go off island to find the care that I need. And now you're here.
Yep.
And as a Staten Island guy, Staten Island roots,
Yeah.
you know the community.
Absolutely.
So I guess my first question would be to you also is, so if someone's coming to see you, because it's such a specialized area, how do you go about that initial first exam when someone comes in so you can determine what's actually going on here?
Yeah. So one of the things I really like about rheumatology is we often play the role of detective, and we're also often, referred from someone's primary care doctor or another specialist. You should go see a rheumatologist. This sounds, a little strange. So the complaints we get, the issues that come to us are very, very vast. We get things from simply like joint pain, ow, my joints hurt, or ow, my muscle hurts, or something, I'm losing weight, I'm losing hair, I have a fever every day, I have ulcers and cuts in my mouth, my hands are cold and they're changing colors, all kind of weird symptoms. And it's really hard to kind of piece things together. So often people get sent to the rheumatologist because they just want help to kind of figure out what's going on. In my initial visit, I'll of course get the chief complaint, kind of what's bothering them, what's been going on. If it's something simple, not simple, but if it's something like pain, I'll try to get a little bit more information about that pain, the location, the intensity, the quality, when did it happen? Were there any triggers? Was there a trauma? Was there a fall? And then I'll try to get associated symptoms. Sometimes people are having pain and haven't even made a connection. Psoriatic arthritis is a great example. People who have a diagnosis of psoriasis affecting their skin, that can be deeply linked to arthritis. So some connection might not have necessarily been made linking their skin condition with the joint pain that they're having now. So trying to make those connections, look for associated symptoms. Are they having fevers? Are they losing weight? Are they losing hair? Other strange things that might be happening. I like to try to get to know them a little bit. Their occupation, that sometimes, their exposures that they might be having might give a little piece or a key as to what's going on and trying to figure out what's wrong with the patient. And then, of course, examining them, and basically just talking with them and trying to configure a plan. Where can we go from here? How can we best help you? And if I can help you, well, at least maybe through that in detail and an in-depth discussion, maybe trying to target them in the right direction, perhaps. Because we are internal medicine trained, so we do understand a lot about the heart, the lungs, and that sort of thing. Yeah.
Are there any conditions that you're seeing here on Staten Island presenting themselves more than others?
There is, yes. There is a very absolutely interesting case in the hospital right now at RUMC. I was just consulted on Wednesday or Thursday. Fascinating case, very sad. I mean, I'll withhold a lot of the information just for purposes of HIPAA protections. But very young woman has some other comorbidities, diabetes, poorly controlled, unfortunately, and at the young age of 39, presented with a stroke. And when they've done imaging of her brain, there's kind of narrowing of the vessels all throughout her body. We see this, maybe it's due to atherosclerosis, maybe, you had a stroke because you're older or you had a clot that spread somewhere. But the narrowing of her vessels are so pronounced and so, throughout her entire body that we think it's a type of vasculitis, inflammation of the blood vessels that's leading to kind of this young woman to have this kind of devastating presentation. That is, of course, a very extreme example. I am, of course, seeing, in the office, I'm seeing really, interesting cases, things like, rheumatoid arthritis and psoriatic arthritis, lupus, psoriatic arthritis, things that, well-versed in and apt to treat. So it's been really nice.
It's probably not surprising, though. I mean, it's well known that Staten Island has the worst health out of any of the boroughs.
Yeah. Yes.
So obesity and other things that are leading factors in that. You probably see more pronounced conditions and different things that...
Yeah, these can be really challenging conditions. They can go on for a long time. People often are minimizers, I've noticed, throughout the city, but on Staten Island, my knee hurts, my knee's swollen, no big deal, kind of pushing it off. That's kind of one of the dangers, because if you keep pushing it off, that joint can get inflamed, that joint can lose function, and you can, sometimes get contractures in your knee or contractures in your hands, where the hands get deformed or the feet get deformed. And that could just be something that we could have prevented if we caught it early and started treatments early.
Yeah, I think it's like society in general, and I think we're all guilty of it. We don't run to the doctor for every ache and pain.
Sure.
And some people, the ache and pain will go on for weeks, and they still take Tylenol. I'll manage it, and then finally it gets to a point where it's so bad.
Right.
All right, I'm going to go to the walk-in center, or I'm going to go to my primary care, or I got to go to the emergency room, and then you find out it's this
Something more.
And I think it's just the nature of. People don't want bad news.
Yeah.
People don't want to be seen as, I can't handle pain.
Right.
And that's what I think happens with a lot of people, myself included, people in my family. And then when it finally gets to a point that I think I need to go to the emergency room, now it's like, okay, and you get there and you think you're just going to be seen. And then they say, well, you have to have a rheumatologist come in. I'm willing to bet there's a lot of people who don't even know what a rheumatologist is. So this
My parents didn't know what a rheumatologist was until I became one. They were like, "Oh, rheumatologist, nice. What's that?"
Yeah, and you see a cardiologist. Everybody, all right, cardiologist. I get that. And I think what you just pointed to, just in the sentence you just said, is arthritis is kind of this umbrella.
Yep.
But there's how many different kinds of arthritis?
Over 200.
Wow.
Yeah, really?
Yeah. Over 200 rheumatic conditions that there are.
Wow. Rheumatoid arthritis is the one that I've heard of the most.
Sure, that's the one. It's all over TV. I feel like every other commercial is one of those newer drug therapies that are available, thankfully.
Right.
But that's the one that everyone knows about. And some people come and they say like, "Oh, I have rheumatoid arthritis." But what they actually mean is they have osteoarthritis. And I think there's a certain level of educating and trying to figure out, do you have rheumatoid arthritis? Because that's what people hear, but they don't necessarily know that arthritis is more nuanced than that.
And is there a way that if someone is sitting at home having trouble with a knee or flexing, how to say, okay, I've got something going on here, or it could be arthritis? How do you make that?
Oftentimes people go to their primary care doctor and do explain these things, and the primary care typically is very apt to get the right questions. I think the primary cares I have worked with are really good at trying to get a general sense of what's going on with their patient. Looking at things, when they come to a rheumatologist, if the PCP, the primary care doctor, is a little bit confused or doesn't know quite where to go next, they often refer, and that's that's great, because again, this is what we specialize in. So what I will do as their rheumatologist, I'll try to get a sense of where their pain is, when it started, how often it occurs. Is it episodic? Is it I'm normal, and then my joints really hurt for 3 or 4 days, they get red hot and swollen, and then they become normal again? Or is it something that you deal with on a daily basis? When did it start? How long has it been going on for? Is it only in the morning? Is it only at night? There's a lot of factors that go into it. And then sometimes, most of the time, an exam is really required. During the months of telemedicine we were doing during the pandemic, it was a nightmare because people will explain their pain. Sometimes patients have a really hard time explaining their pain. And if you've ever tried to do it, it is actually kind of tough when someone asks you, like, what is your pain like? They often are stumped and they have to think about it. But the exam is really, really important because you want to see if there's stiffness in that joint. You want to see if there's swelling, how they can range it. Can they move their joint the entire way? Can they make a full fist? And these are things that we weren't really able to do well on Zoom or on FaceTime or what have you. that's pivotal to determining, is this just osteoarthritis, kind of that wear and tear that we get with aging, or is it something more insidious like rheumatoid arthritis? And then the blood tests really put the kind of final pin on the board that helps kind of clarify, because there are certain blood tests and autoantibodies, proteins in the blood that shouldn't be there, that help kind of solidify the picture.
Gotcha.
Are there any non-medical methods that you use to help patients, with their pain? Anything that you
Yes,
recommend?
absolutely. A lot of patients will, don't like taking medications for whatever reason, can't take certain medications because of other comorbidities that they might have. I will often talk with the patient and try to get a sense of what their goals are and what they're looking for and how I can help them. For certain things like osteoarthritis, that age-related arthritis I was talking about, things like topical medications, so like Voltaren, a topical cream, stretching exercises. There's a lot of evidence actually for acupuncture in patients with osteoarthritis, particularly in the back. Things like physical therapy absolutely is kind of a gold standard for a lot of these patients, because you want to strengthen their muscles, strengthen their the supportive tissues around a joint that might be bothering them, basically just getting them stronger. And those are the kind of main, non-pharmacologic, non-medical treatments that we use, yeah.
And you mentioned before about the pandemic, and you're in a field where you really need to physically see somebody.
Yeah, yep.
And a number of doctors have said, as a result of the pandemic and that telemedicine,
Yep.
that you couldn't get that exam like you could physically touch. So are you seeing now certain conditions that you would say are exacerbated because there was that period of time where people didn't or couldn't go to doctors and be seen regularly?
I think that it is starting to level out.
Okay.
I think the answer to your question, if you asked me 6 months ago, yes, I think it's starting to level out. Fortunately, I feel like we're coming out of the tunnel that is the pandemic, or was the pandemic. It definitely is leveling out. I think a lot of people were neglecting their health, had a harder time getting some of their medications. Hydroxychloroquine, Plaquenil was a medication that we often use in patients with some of our autoimmune conditions, and that medication was thought to be potentially useful in COVID. So some of these patients with lupus or rheumatoid arthritis who were on Plaquenil were having a really hard time getting their medications in the initial parts of the pandemic, because it was thought to be effective in COVID treatment. So that was a challenge. There was actually some of the medications that we use were very hard to get, were in shortages during the pandemic. So that all played a role in just not being able to get into your doctor, not feeling comfortable to go to the pharmacy to pick up your meds. It did affect people very much in the very beginning, but I think it's fortunately leveled out, and hopefully we never have to deal with that again.
And you're practicing now how long?
I've been practicing. So I've been practicing in rheumatology for the past 5 years.
5 years.
Yeah.
Has the field of rheumatology changed from the time you started to now, even though it's only 5 years?
Yeah, it absolutely has. So I'm entering my 6th year, I guess you should say. The field of rheumatology, and that's something that drew me into the field to begin with. Just to kind of go backwards, in the 1960s, 1950s, we had no effective treatments for rheumatoid arthritis and lupus and things like that. We were actually infusing people, if you can believe it, with intravenous gold. We were giving people intravenous gold in the 50s and 60s.
What is that?
For rheumatoid arthritis. I don't know. It doesn't work.
Who thought of that one?
But it was that's what we were giving people, and there was some anti-inflammatory property was the thought process, but it was not very effective. These patients were losing their joint mobility. They were getting contractures in their hands. Nothing was effective. In the 60s, 70s, fortunately, we started to get a little bit more lucky with some treatments, things like steroids, prednisone, Medrol, these sort of medications. They are very effective. They don't really change the course of the disease, but they at least gave people a quality of life, and they were treating the symptoms effectively. They unfortunately can be very toxic, lead to side effects when you use them from a long period of time. But then when you look at, the 90s and certainly the early 2000s, we started to see an explosion of treatments. And then even in the past 10 years, and certainly when I've been practicing, more and more medications are being, thought of and going through rigorous clinical trials and being approved by the FDA and now used. So, within the 5 years, probably 10, 20 drugs have been approved. I don't know the exact number, but that sounds about right. Have been approved and are all very effective for the treatment of rheumatoid arthritis, lupus, vasculitis. So it really is an exciting time, and we're just figuring out more and more about these diseases. So it really is a very exciting time to be a rheumatologist.
Absolutely.
Yeah.
And say for a patient with a chronic condition, something like lupus, what do you recommend to them if they're considering something like pregnancy and then they're on all these medications?
That's it's a very good question, and a lot of these conditions, particularly lupus and rheumatoid arthritis, can affect people and do affect people primarily in the prime of their life, in their 20s and 30s, when they're thinking about having kids, or potentially earlier, potentially even later. Fortunately, patients with rheumatic conditions tend to do a little bit better actually when they're pregnant, because
Really?
the immune system has to allow for the baby to be in the uterus of the woman, and the immune system calms down and their symptoms will often improve. So that's a good thing. The kind of bad news is it requires a lot of planning. There can be really adverse pregnancy outcomes in patients who are on certain medications. So you want to speak with your rheumatologist, you want to speak with your OB-GYN before you're pregnant to make sure that some of the medications you're on are not going to potentially adversely affect the baby. Some of these medications need to be stopped, 3 months before conception, or they can lead to, birth defects. So you really want to be looking at what medications you're on, thinking about when's the optimal time to get pregnant. You really want the disease to be quiet before you get pregnant, because then you optimize the potential that baby will have a very successful kind of event-free 9-month period while they're forming.
So you're working very closely with other fields.
That is probably one of the best parts about being a rheumatologist is, well, I guess I said the treatments, but it is among the best things about being a rheumatologist is that we are very multidisciplinary. We work with their cardiologist, we work with their pulmonologist, their endocrinologist, nephrologist, because our diseases can affect any part of the body. We talked a lot about the joints, but it can affect, these rheumatic diseases can affect the heart, can affect the lungs. Rheumatoid arthritis, the leading cause of death is cardiovascular disease. So we want to be working with these other providers to make sure, okay, let us take care of their joints and their autoimmune disease, but there are other things we need to be thinking about. And I think, cardiologists are very heart-centric and nephrologists are very, kidney-centric, but we try to bring everything together and kind of unify the picture and think of people holistically.
So are most of your patients referrals from primary care physicians, or people picking up the phone and saying, hey, again, I don't know how many people may not know what a nephrologist is, but is it mostly referrals?
So people can self-refer, and I feel like that's becoming more common. People go on Dr. Google and type in their symptoms and be like, maybe this can be autoimmune. Let me go see a rheumatologist.
Yes.
But I think the vast majority are through referrals. We get referrals through both avenues. I think PCP primaries are probably the most common, I would say. But yeah, I get referrals from neurologists, from renal doctors, kidney doctors, cardiologists all the time. So referrals come in from kind of all avenues.
So you mentioned a lot of the common conditions, like is MS or any other conditions like that fall into what you...
So there are autoimmune conditions that are not necessarily managed by a rheumatologist. MS, for example, multiple sclerosis is one of those conditions that we thought to be immune mediated in nature. Primarily has neurologic manifestations, so that's primarily managed by a neurologist. Though we often will work with them in certain instances. Things like Hashimoto's thyroiditis, kind of thyroid conditions. These are autoimmune in nature, but because it's primarily affecting the thyroid, they primarily follow with an endocrinologist, for example, a thyroid doctor. So it varies. It kind of depends on the condition, but like I mentioned, we'll interact with a lot of these doctors because, first of all, the autoimmune conditions tend to run together. So if you have type 1 diabetes, or if you have a thyroid condition, you're more likely to have another autoimmune condition at the same time because your body is making similar mistakes, so to speak. So, it's a possibility. So we get, that's why we get referrals all over the place, and that's why we interact with so many other specialties.
Do you have a patient who was most memorable to you that might have affected you in some type of way?
That's a good question. Let me think. I'm inspired by my patients and think about my patients all the time, and a lot of them have been very memorable. They go through a lot. They have difficult lives and difficult challenges, and kind of seeing them grow has always been, and kind of succeed and get through their condition has been really a joy and kind of the most gratifying thing in my job. But a particular patient, I think probably the one that made me go into rheumatology is probably the most impactful. I did a rheumatology rotation in my residency, but it actually was on a cardiology rotation. There was a patient who was going into heart failure. He was kind of older, and he was a healthy guy, we could not figure out what was going on with him. We did, some tests, and ultimately it came out that it was a condition called amyloidosis, which is quite rare. And is in part managed by rheumatologists. And, we kind of, put the pieces together. We saw something was going on with his heart. Something strange was going on with his kidney. We did a physical exam. We noticed some interesting findings in amyloidosis. You get something called macroglossia, and you can get something called the shoulder pad sign. And we were like kind of putting things together, and we said, We ordered the right tests. We sent the right things, and we did a biopsy, and lo and behold, it was amyloidosis. And, it was just kind of the aha moment for me. I think that was like, this is what I want to do.
Cool.
That's awesome.
Yeah.
Just to get a little personal with you before we wrap things up.
Sure.
So we have Dr. DeMizio, rheumatologist / detective. I'd love to know, in your off time, what you like to do to decompress, and any hobbies, anything that you have.
I'm a pretty low-key guy. I think I'm introverted by nature. A lot of this, I think I can, interview patients and talk with patients, and it takes a lot of energy to do that. So when I go home, I just kind of want to relax. I love having, family quality time. I'm a big fan of movies. I think that's something we share, Alex. So I'll watch movies, TV, obviously, read books. I'm a big fan of fiction, nonfiction. Finished all of Game of Thrones. So waiting for the next, the show, love the show.
House of Dragons.
House of the Dragons has been fantastic. So I've been reading kind of those books, waiting for the next book to come out.
We might be waiting a while.
A very long time. It's been, it's so funny because I went to medical school, finished medical school, went to residency, finished residency, did my fellowship, finished fellowship, did 3 years of being an attending, and now I'm here for my 4th year. And the book has still not come out yet.
Still not come out.
I don't know, George R. R. Martin. I don't know if you're listening to this podcast.
Yes, and he's now 74, 75.
Yeah. So we're hoping for the best, but preparing for the worst.
Exactly.
He's got to get on that.
Exactly.
So reading, kind of just hanging out, relaxing, seeing family, friends, hiking, that sort of thing. Just relaxing.
Nice.
Yeah.
Very nice. Well, I'd like to thank you once again for your time and for all that you do to keep us safe and healthy. We're happy to have you as a part of the RUMC family. And thank you once again.
Thanks for having me.
That about does it for this episode of RUMC Connections. Thank you for joining us. I'm Meredith Gaskins.